Welcome everyone. My name is Tracy Moore and I'm the Director of Population Health at the National Rural Health Resource Center. I'm also the Program Manager for TASK. And welcome to Breakout 1A about administering federal rural health grant programs from state, nonprofit, and university settings. So first I'm going to orient you into the breakout room space here because it looks a little different than the portal that we are just in. And then I'll introduce the session learning objectives and the speakers to you. So all sessions are being recorded. If you have any technical difficulties during this, we encourage you to use the chat box at the bottom of the screen. We also encourage your questions and interactions with the presenters. And so for questions or technical difficulties, again, during this session, use the chat box at the bottom of the screen, or you can verbally ask the question. We prefer that if you have any technical difficulties, those go into the chat box and we can respond to those accordingly. So to ask a question, you can click on the icon labeled participants at the bottom of your screen. And as you do that, it looks like a couple heads. If you click on the little caret up arrow for that, you can open the participants. And within that feature, there are three dots to the right. There is an opportunity within this to be able to, there's an opportunity in this to raise your hand. I'm not seeing that feature right now. So I guess what the best opportunity to do to ask a question is to simply unmute yourself at an appropriate time or to type the question into the chat box. So the learning objectives for this session include the following. We'd like you to be able to compare best practices and lessons learned for administering and integrating efforts across FLEX, the Small Rural Hospital Improvement Grant Program, or SHIP, and the State Office of Rural Health Program, or SOAR, from a state government, a nonprofit, and a university setting. We'd like you to be able to identify innovative models of care that can be implemented by critical access hospitals and to apply various approaches to support those CHs that are facing challenges. So with that, I'll introduce to you the four different presenters that we have today for this session. Stephanie Nance joined the North Carolina Office of Rural Health as the Assistant Director, in June of 2015. She directs program operations, including the Rural Hospital Program in the North Carolina Telepsychiatry Program, the Community Health Program, the Medication Assistance Program, the Farm Worker Health Program, and the Placement Services Program. Stephanie has dedicated the past 28 years to providing or administering public and nonprofit human services that primarily support underserved populations. Sarah Craig joined the South Carolina Office of Rural Health in 2015 and currently serves as the Director of the Health System Innovation Team. In this role, Sarah provides targeted support to rural hospitals, emergency medical service providers, and primary care providers in South Carolina. She's responsible for engaging the state's 4 critical access hospitals in quality improvement activities and initiatives. And she oversees the requirements of several funding sources related to this type of work, including the FLEX program and its EMS supplement, the SHIP grant, a Duke Endowment Community Paramedic Grant, a Rural Hospital Workforce Grant, and the University of South Carolina School of Medicine EMS Leadership and Tuition Assistance Grant. Kayla Combs is the Rural Project Manager for the Kentucky Office of Rural Health, where she oversees the FLEX program. In this role, Kayla works with the state's 28 critical access hospitals to further their quality improvement and financial stability efforts to ensure continued access to these services for rural Kentuckians. Kayla's worked for the Kentucky Office of Rural Health for the past 8 years and in her current role for the last 7 years. And Chris Salliers serves as the Education and Services Director at the National Organization of State Offices of Rural Health, or NOSOR. Prior to this position, he was the Rural Project Manager with the Kentucky Office of Rural Health, managing communications, workforce, networks, and special projects. Chris's career began as a peer support specialist for adults with severe mental illnesses and substance use disorders in Eastern Kentucky before completing a counseling degree and moving into SAMHSA and HRSA grant programs. Chris holds a Doctor of Health Services from A.T. Still University, where his research focused on comprehensive access to primary care in Appalachia. So with that, I will turn it over to Chris to open up our session.
Thanks so much, Tracy, and thanks everybody for joining us today. So a lot of familiar faces out there. It's good to see. And this is my first time being at a Flex Reverse site visit virtually or in person, so I'm really excited to hear a lot of what you guys are going to say today. A little frame up before we really dive into this, just a couple minutes, and then I'll be quiet and turn it over. But I'm here today because to tell you guys a little bit about a project that we're working on at NOSOR in collaboration with TASC and FORHP. And it's a tool that we're looking at as to how to try to help you guys think about integrating your Flex, SHIP, and SOAR grants, right? How does one support the other? And how do you structure that office in different ways, in different settings, university, nonprofit, and state government, with a different combination of grants, right? So that's what we're going to talk about today, and that's going to lead into a focus group that NOSOR and TASC are working on some questions right now with FORHP, and we're going to move through this process of trying to pull together a resource that really helps you guys think about that process of how one grant can really support the infrastructure of the other. So for this presentation, we're going to talk about kind of the best practices and some lessons learned there around administering those grants. We're going to look at some innovative models that each of the three states, amazing Flex programs, and I'm really honored to be up here with you guys. So some really innovative models that these states have done, and where they struggled, right? What are some lessons learned out of this? What were some challenges and how they overcame them? So I hope you guys really enjoyed this session today, and look forward to working through all of this and talking to some of you about the great work that you guys do in terms of looking at different ways to really integrate these projects. So with that, I'm going to turn this over to Stephanie to get us started on a state government perspective.
Thank you, guys. Well, welcome to the session. And Chris, if I just say next slide, you can go ahead and go to the next slide. I don't think I can control that from here. But welcome everyone. I'm Stephanie Nance. I'm Assistant Director of the Office of Rural Health in North Carolina. I have been with the office for about 5 years. And I'm here kind of with and for Nick Galvez, who is our awesome rural hospital program manager. He has been pulled into a lot of work at the Emergency Operations Center because of COVID. So he and I had a long talk, and I said, well, I'll take the helm for this so you can be where you need to be. So thanks, Nick, for all your great work, because most of what I'm going to share today is attributed to him and his strong leadership. So if you'll go to the next slide. So we're the North Carolina Office of Rural Health. We were the very first state office of rural health created in the nation. Really proud of that. And the SOAR grant grew out of the fact that we were established, and we're really pleased to say that every state has a state office of rural health, and we're glad to be part of that legacy footprint. Our whole office mission is about creating access to care. We have a team that varies between somewhere in the mid-40s. Sometimes we dip up into the 50s between interns and temp employees, but it kind of ranges. We typically have a budget of about $40 million, of which we push nearly 80, sometimes 85%, sometimes a little bit more, out into rural and underserved communities. So we're really proud of the amount of money that we can get out to our rural communities every year. We have 100 counties here in North Carolina, and 70 of those counties are considered rural. So if you go to the next slide, I'm going to talk to you a little bit about our office and our programs. We're one of the largest state office of rural health in North Carolina, and it doesn't mean that North Carolina does things necessarily different than other states. It's just that we're all under one roof in one organization. Now, we do have some unique programs, and I'm going to quickly talk through those, and I'm also going to talk about how we align these programs and this work across to ensure that we're maximizing resources. So first off, we have the Rural Hospital Program, and Nick leads that, and that is where our Flex and SHIP programs live. That team also oversees the North Carolina Telepsychiatry Program, and that is a program that's funded through state appropriations, and it was created to provide consultation in emergency rooms when a patient presents with behavioral health, mental health, substance abuse needs, to determine if that individual can be safely released to the community or if they need a higher level of care. That program has been expanded into non-ER settings in the last year, so we're really excited about that program. We also have the Community Health Grant Program, and that is a program where the North Carolina General Assembly provides us with nearly $15 million a year that we use to provide grants for primary care access. And a way that that benefits the hospitals is many hospitals in North Carolina have primary care site clinics that they can now apply for those funds. And also, if a hospital does not have a primary care office, then frequently local primary care safety net sites that acquire those funds work closely with the hospital to reduce unnecessary ER visits and work on population health. So that's how those two programs integrate. Another program we have is the General Assembly gives us about $2 million a year for a medication assistance program. And that's a program that supports individuals who cannot afford their medication to acquire those medications for free. And we use a background database platform called the Pharmacy Connection, so that you don't have to search through all the individual pharmacies that are not pharmacies, the pharmaceutical companies that are willing to donate the medications. This platform links a person's eligibility with the agency that's willing to donate, and it generates the match. And many of our hospitals have the medication assistance program embedded in them, and they have grant funds through that to pay for that. We also have a program called the Rural Health Centers program, and that's a special program that I think only North Carolina has. We have an appropriation about $2.5 million, and we have the authority by the General Assembly to establish and to help sustain primary care sites that we designate as a state office of rural health as rural health centers. And so they're outpatient primary care locations across our state, and we work hard to create those where there is deserts of primary care. And then we have our farm worker health program that is also funded by HRSA, and we have to act just like an FQHC and meet all the requirements. But instead of providing direct care ourselves, we do the care through vouchers to sites. We have our rural health information and technology team and our analytics and innovations team. Those two teams help with utilizing ER and also electronic health records. And also they work on special assignments. Right now we have a big community health worker initiative that is growing up and being developed, and we've done a lot of mental health first aid. And then we do recruitment services and placement services. And in addition to being the PCO and doing the HIPSA and being the National Health Service Corps TA arm, we also have an appropriation from the General Assembly of about $1.5 million a year that we can use for loan repayment or high need service bonus. So I've kind of tried to talk through all those quickly, but our SOAR grant is connected most closely to the Rural Health Center program. And the SOAR grant primarily supports infrastructure so that the other programs can support the SOAR work by providing technical assistance and outreach and linking to resources. And the nice thing about our state is we have a lot of internal resources that folks can access. All right, so next slide. Okay, this is a map of last year's coverage, and you can kind of get a sense where all of our grantees are and where our funding touched. And the green means it's considered a rural county, and the gray means it's a urban county. I'll let folks look at that as they'd like to, but next slide. Most closely, Chris, next slide. Okay. Most closely related to our presentation today is where our rural hospitals, we have 31 small rural hospitals, of which 20 are critical access hospitals. And you can see they're sprinkled mainly in the west and a lot in the east, and but they're sprinkled all across. All right, next slide. All right, so then we've got our Flex program here. And our Flex program supports 2 FTEs, travel equipment, and then we contract our technical assistants out. Now, I'll talk to you a little bit about the strengths and weaknesses of being in state government, because we have to do things a little bit different because we're in state government. One of the things you're going to see real quick here is we have to do a competitive RFA. We're required to do that because we are located in state government, but if you are operating the Flex program outside state government, you might not have to take that step. The other challenge with being in state government is the state is going to pull indirect rate costs based on FTE. So some of our funding that comes through from Flex automatically gets pulled because of the number of FTEs that are supported in that particular grant. And I'll talk to you a little bit about the different ways that we've administered the Flex program over the years. When I came on, we had one primary contractor that did TA, and most of the work with our 20 critical access hospitals was group work, where we're bringing them together at statewide meetings and doing training and technical assistance. We're bringing them together to talk about the projects that they would like to work on in the upcoming year. But it was a lot of group work. And then we've moved our Flex program to contracting with two different contractors, one to focus on finance and operations and one to focus on quality improvement. And we have also moved our strategy to providing technical assistance in a statewide cohort where we're bringing everybody together as a state. And then we're also providing technical assistance at a smaller level where we're pulling the hospitals together based on the region, based on who's close to them, and doing more pointed TA in the group with those hospitals. So we might get like 5 to 10 hospitals together out of the 20. And then the third level, which we just started last year, and we didn't know how it was going to go, but it's gone quite well. We have a smaller pool of competitive project-based technical assistance work that's granted to 4 to 6 critical access hospitals a year. And some folks said, well, what about the ones that didn't get picked this year? Are they going to get mad? So far, they have not. And so far, we haven't, of the 20, we tend to get 4 to 6 applications every time. So it's not like we've had to really turn somebody away. And if we did, we kind of let them know it's available next time. All right. Let's see. Next slide. I'm trying to go fast because we said we have about 10 minutes each. All right. So our SIP grant, as you can see, we get, just like everybody else, we get a certain amount for each hospital. With the typical SHIP award, there's not a lot of incentive for the hospitals to contract with our state process for $10,000 to $12,000. Our contract, if you ever see it, because we're located in state government, it's like 30 pages long. You have to submit all these forms and provider documents. So we've typically administered our SHIP program by contracting with one contractor who then directs the funding to the hospitals. The other barrier with being in state government is we have to have folks spend their money and then send us a receipt. So by going with the contractor, that eliminated that barrier for the hospitals. One thing that COVID helped us do is with the $84,000 we received, we did break the seal and contract with each of our small rural hospitals individually. So the good news about that is all those provider documents and that creepy long contract, they've all experienced it. So I think we're going to be in a different position moving forward with whether or not we want to contract with those hospitals individually. But the biggest change this year that we're doing with our SHIP is we have purchased technical assistance in advance for them. So instead of tracking invoices and keeping up with costs and turning in receipts and all of that, we have 2 contractors, and they're the same 2 contractors that we work with the Flex program to create alignment across the Flex and SHIP programs. But all those small rural hospitals have to do is pick 1 or 2 projects and raise their hand and say, this is what we want to work on. And we deploy the technical assistance to them so that we are contracting directly for all that. Now that's something what we're just trying this year, and we'll see how they like it, but I'll let you know. All right, next slide. All right, innovations. We have a lot of really great work we're very proud of here in North Carolina. Cannon Memorial Hospital up in the mountains got a CMS waiver to increase their bed capacity for behavioral health beds, and you can see they reduced their acute care beds, and now they have 27 behavioral health beds attached to their critical access hospital. So we're very, very excited about that. We've got the Anson Hospital, which is a small rural hospital, and they redesigned their whole building and structure so that when you walk into the emergency room, you get an immediate assessment. And if you have a true emergency, you go to the left and go through the emergency department. But if you have a primary care need, you go to the right and you're seen immediately by a primary care provider. Once you go past those doors, the back part is completely open. So you're just in this one big area so they can flip beds from being a primary care room to an emergency room. So that's a really neat design. We're real proud of it. And then a really interesting thing, population health-wise, First Health Montgomery did is they implemented the Daily Mile, which is a project that came out of Europe, where you're having school-age children as part of their education and curriculum walk for a mile during the day, during the school day, or run. And they've implemented in all their elementary schools. They're moving to middle schools. And if you're familiar with rural communities, a lot of times there's no place for citizens to go and get some exercise without walking on the side of a road. So so that creates a recreation space to help the population be healthier as a whole. All right, next slide. Trying to hurry, I'm talking too long. Okay. So addressing challenges, one of the benefits of being inside state government, I talked about some of the challenges with, we got this big contract, you have to spend your money first and get receipts. Well, they're going to pull indirect rate based on your FTEs. One of the benefits is being inside. So we are in Department of Health and Human Services, and guess what? So is Medicaid. So with COVID, we worked really, really, really hard to get a increase for our swing bed rate. And so it went from $129 a day to $1,200 a day if a critical access hospital is treating a COVID patient, and $861 a day if a critical access hospital is treating a non-COVID patient. So what this is helping us do is if there's a surge at the large facilities, it allows the large facilities to transfer patients when appropriate to the critical access hospitals to free up their beds, and it makes sure that the critical access hospitals are kept whole for that. So we're proud of that. And then Nick is embarked in a multi-state collaboration with North Carolina, Florida, and Virginia. And so for our August statewide meeting, for our flex meeting, where we're bringing our cause together, we're going to have a joint meeting with a couple of other states. And I think that's it for me. And I'm sorry I talk so fast, but I'm trying to leave time for the other presenters. Call me anytime, email me anytime, and hopefully we'll have some time for questions at the end.
Great. Thank you, Stephanie. Next slide. Perfect. Well, my name is Sarah Craig. I work at the South Carolina Office of Rural Health. I have the pleasure of working with Dr. Graham Adams. We are a nonprofit Office of Rural Health, and I am very grateful to be working in that setup. I feel very deeply for those who work in a university and DHEC or HHS office. That's, you guys face a lot of challenges that we don't necessarily face at our office. So next slide. So our office was established in 1991, and we gained our non-for-profit status in 1995. We are located centrally in South Carolina. Our office is in Lexington County, but we are right next to Columbia. We currently have about 40 staff and 2 office locations, and about 32% of our state is considered rural. Next slide. So the work that we do, we only have 4 critical access hospitals in South Carolina. We had one closed at the end of 2018. We've had 4 hospital closures across the state over the last couple of years. So we have 4 critical access hospitals and 12 SHIP hospitals and 24 rural hospitals. So this definitely tailors our work differently. Where we do a lot of in-depth work with each of our hospitals. We're able to work on activities and focus work directly with what that critical access hospital needs. So our funding sources is about 50% rural, 43% is from South Carolina, and then there's some other funds. Next slide. So I just kind of want to briefly talk about our main programs at our office, because our SOAR, Flex, and SHIP grants definitely help either grow or started the seed funds for these services and initiatives, or they still are within those grants. So we have the Center for Practice Transformation, which really helps our provider-based and non-provider-based RHCs, so rural health clinics, to pursue patient-centered medical home recognition in South Carolina. Also, they work on looking at access and looking at their capacities and looking at their, if they can start seeing more patients within, like streamlining their patients and their, their systems that they use. So it definitely started out focusing more on patient-centered medical home, but it has transitioned to helping the practices be more nimble in today's healthcare environment. The next one is that I want to talk about is our rural EMS services consultation. So we do a lot of work with EMS across South Carolina on the state level, and then with individual agencies. We have secured the EMS supplement grant. So that's, has definitely flown from our Flex EMS work in the past. We've done a lot with community paramedic and we have a state fund that allows us to support EMS leadership training and tuition assistance for all 3 levels of EMT in South Carolina. So we have a very extensive outlet there, which is fantastic. We have a revolving loan fund within our office, which helps support our rural providers if they need access to capital for improvements within their facilities. So that's, a very valuable service that we have. We do some work with rural veterans across South Carolina, and we work with the VA as well. We also have recruitment and retention services and support in South Carolina, and that's huge to our rural hospitals because, having a agency, paying for an agency to help with your, with their workforce that they're having shortages with is definitely helpful for us to kind of help navigate that with our hospitals. We have a quality payment program consultation. So we are a subcontractor for Alliant to work with the QPP in South Carolina. So that's, something that we are really proud of and glad that we can help support that process as well. We also work on a lot of community programs that is really starting to branch out outside of, the traditional work that we've done, and really focusing on the health of communities and how we can start linking, everything, the whole person care to the services that we provide. Also, we have recently dived more into our Rural Health Action Plan and what we call the Rural Forest South Carolina. And it's really looking at broadband and food insecurities and food deserts in South Carolina, housing issues and education, and how all that affects health. So next slide. Next one. So these are the activities. I just briefly wanted to talk about these for our SOAR, Flex, and SHIP grants. You can see the program activities for Flex and kind of the things that we focus on, and those were for fiscal year 19. And for SHIP, we focused on payment bundling for all of our hospitals, and its efficiency and quality improvement training or pricing transparency training. So that's our area of focus for the next couple of years. Next slide. So Mark Griffin within our office, he administers the SOAR grant, and this grant provides most of the infrastructure for our flex and SHIP grants. It covers salaries, travel, and equipment, and it really allows most of our flex grant to, for that money to be dispersed to our cause. So next slide, sorry. I started at the office about 6 years ago. I think it's just over 6 years. And I became the flex coordinator in fiscal year 15, and I didn't write that grant. And I was so grateful to be able to write the next grant that we're going to be executing, the cooperative agreement. It's definitely very helpful to write to do the work that you said you were going to do. It's very difficult to start working as a flex coordinator, executing a grant you didn't write. So this grant provides my salary. It's a full-time position, obviously, because that's a requirement in flex, but it also covers a program manager, and we are able to tailor activities right to our critical access hospitals, and we coordinate all of our contracts with the hospitals or the consulting firms based off of the hospital's needs, which is really helpful because sometimes the hospital has a preference on who they would like to help assist with projects, or they're already engaged within the culture, and we find that we can get a lot more work, higher quality work done, being able to kind of be more nimble with who we contract with. So past activities include, we've done level 4 trauma designation, and we're able to kind of do more of a statewide collaboration with that. So it's all the rural hospitals giving them an opportunity to step into the trauma world in South Carolina. So we have quarterly quality meetings for our MB Equip with the COG clinical staff, and those were happening quarterly, and they transitioned to twice a year. But that really helps us to kind of really go through the quality reporting and allows them to show their quality reports to the whole CAW, our 4 CAWs. And they really haven't pushed back on, being collaborative and sharing that data amongst the 4 hospitals, which we're really proud of. We also worked on establishing a 340B pharmacy with our fiscal 17 flex supplement. So that was a great opportunity to really help one of our critical access hospitals. We've done a lot around swing bed program improvement. We found that over the last couple of years that rural hospitals are definitely doing swing bed, but they don't feel very confident in the services and their programs that they do. So we really started to highlight and strengthen those programs. One of the big things that we've done over the last several years, last 5 years, is our HHS office did a hospital sustainability plans, which really helped our small rural hospitals look at kind of where things were going long term for them. And over the past 10 years in South Carolina, there has been a transition from the independent hospital to system, and we've really seen that over the last couple of years. So, we were really able to really partner with our HHS office and really able to help support those rural hospitals. So, next slide, please. So our SHIP grant is a little bit different. Like I said earlier, we have 12 SHIP hospitals, and we utilize our SHIP funds into a network. So we pool all those funds into the network, and we, highlighted the area focus that we were going to identify for our SHIP hospitals. And then each year we send out a survey and we kind of gather additional information on, what activities they want to participate in, which, what areas that they want to expand into. And so each year we send that survey out, and when we do our non-competes, we have to get the hospital applications. We fill out the hospital applications. We highlight the areas that they need to fill out and kind of streamline that whole process. The SHIP COVID funds really helped us to kind of open doors for other hospitals that haven't participated in the SHIP grant prior. So we have 2 additional hospitals that meet the criteria for being eligible for the SHIP grant, which we're really excited about. So past activities included, we've done a lot around certified revenue cycle analyst training. We've done a lot around ICD-10 billing and coding classes, and have done a lot of these trainings have really been tailored towards our provider-based RHCs. So, next slide. I love the work that we do, and like I said, most of our work within the office definitely touches on our SHIP work and flex work, and I, really briefly, high level, went over everything. I definitely am here to share any kind of information or documents that we have with you guys. We definitely want to be as supportive of other state offices. So, thank you.
Okay, hey guys, my name is Kayla Combs, and I'm the Flex Coordinator at the Kentucky Office of Rural Health. And like Tracy said, I've been there about 8 years, and you can see a map of our critical access hospitals there. Ignore what an ugly map that is. And I have listed, not everyone in our office, I have a picture of most everybody, except for Caleb, our newest hire. But I just listed myself and Ernie and Lisa because they sort of helped me put these slides together. I don't do SHIP and I don't do SOAR, so sort of depended on them to help me through this. So we have 28 critical access hospitals in our state. We have 36 SHIP hospitals, and much like Sarah, we were able to add some additional ones in when the COVID funding came available. So we bumped that up to 46, which was really great, and we got a lot of money passed through. Of course, with the university, it maybe didn't take as long as it did with some states, but it definitely wasn't a super quick process, but we got it done. We operate 4 federal grant programs: the State Office of Rural Health Grant, the State Loan Repayment Program, Flex, of course, and then SHIP. And then we have some other initiatives, the Bridge Magazine, and we actually do the National Health Service Corps promotion on behalf of our PCO because we are not state-based, but we have a contract with them to do that. Next slide. So just talking about how we administer those 3 programs, we're a fairly small office. We're in pretty constant communication with each other. We talk even now more so than we did in the office while working from home. We have weekly meetings as a staff, and then other meetings on individual programs. So we always know, what each other's up to, what they're planning. These are joint planning efforts. We look over grant proposals for each other and everything else. So we're really in tune with what each other is doing, which makes it easy to avoid duplication and to just carry out those programs to the best of our ability. So each program is uniquely structured, which also sort of helps avoid duplication. Flex is really heavy on trainings and technical assistance-based activities. SHIP is more like previously approved activities on a reimbursement model. I'll talk more about that in a minute. And then SOAR has, of course, activities in the SOAR grant too, but it also covers a lot of our subscriptions, a lot of salaries to help support the other programs. And it also covers like costs like our TrueServe, website, Tableau, Constant Contact, and a lot of the in-state travel. So the SOAR grant, like others have said, really helps support all the programs under our umbrella. Next slide. So when we look at administering flex, we used to contract a lot of that work through the hospital association. And within the last year, we have brought a lot of that in-house. So we have sub-agreements for a lot of the quality and finance work, but we just sub-agree those out ourselves. We actually don't have contracts this year. They're sub-agreements and they're vendors. So I know Catherine had asked about like an RFP. We thought we might have to do that this year, but we didn't have to. We did the sole source documentation like Catherine had mentioned, and that worked out really well. But it was a big learning curve for us to take those on instead of contracting everything through the hospital association. So flex activities, of course, administered in different ways. We have in-person meetings. We do quality conference, financial network meetings. We have a couple summits, telehealth, RHC. We do network meetings. You can see there others, grant writing workshops, etc. So that's definitely been a challenge in COVID times, not being able to carry out a lot of those activities. We had about half the year to do some of those, and we did quite a few, but we've had to sort of rearrange things and get creative to sort of carry out some of the rest of our work that we want to get done within this grant year. And then we do a lot of one-on-one technical assistance, personalized to the cause, depending on what their needs are. And that could be quality, that could be finance, performance improvement, what have you. And then we offer scholarships too for our critical access hospitals. If they want to travel to a meeting, we can provide scholarships for that. And of course, our staff used to travel to quite a few meetings, not so much this year. And we miss that. But we have sub-agreements with Blue & Company, that's an accounting firm. Stroudwater, I know a lot of you are familiar with them or maybe work with them. Same with Cynosure, they do a lot of our quality work. And then our regional extension center does a little piece of it too. And then, staff have varying amounts of FTEs dedicated to flex, ranging from 20 to 100%. Salaries are mostly split between the flex grant and the Soaring Grant, and just a little bit on the SHIP grant. Next slide. So Lisa was nice enough to give me these next couple slides because she is the SHIP grant coordinator, and she really does a great job. She does a much better job than I ever did and is much more organized. So she has this reimbursement form that she created. She's, like I said, very organized, but it mirrors the purchasing menu. Each hospital marks out what they want to do, and then that is approved by our office and sent along with other purchasing documentation. And we are very lucky that those 36 SHIP hospitals do not have to have individual contracts. They are set up as a vendor in the University of Kentucky system, and we've been really lucky that that's worked out so far, because that contracting process, you guys know what nightmare is a horrible word to use, but it can really be a challenge. Next slide. So here's the reimbursement invoice that she's created, and Lisa told me that she's happy to share any of this stuff with anybody that would like it. I have her contact information at the end of these slides, so please feel free to reach out to her. She's very giving and would be happy to talk to you about any of this stuff. But this is the tracking spreadsheet. It automatically calculates invoice amounts, what's authorized, and of course this is also sent along with the documentation to UK so that the hospital can be reimbursed for those SHIP activities. Next slide. And this is the reimbursement tracker, so it offers an at-a-glance account of all the invoices that have been sent to UK, what the status of the payment is, how many funds they have left. She has it to where it automatically changes colors once all the funds are expended for a certain hospital. Really cool spreadsheet, and that helps her keep track of where everybody's at, and if they have money that's left to be spent, she can reach out and make sure they're going to spend that down. So I know I went through those pretty fast, but like I said, if anybody has questions about those or wants a copy of those, Lisa's happy to share. Next slide. So we were asked to talk about something a little bit innovative that our office is doing. I wanted to talk about our newest project. So this is funded through Flex. It was actually part of that competitive EMS supplemental funding that we wrote for, like a year and a half ago or so, 3-year project. And we were lucky enough to be awarded that. And in January of this year, we hired Caleb Williams, and he is the project manager for the supplemental project. And of course, in March, we all got sent home, but we continue to work on this project remotely, and we've definitely faced our challenges, but our goals are to increase education on effective AED use, increase the bystander CPR readiness at a community level, and then out-of-hospital sudden cardiac arrest survival rates. So we sort of consider this an innovative project, but also related to population health. And next slide. So you can see that our activities, we plan to roll out CARES, which is the Cardiac Arrest Registry, and to enhance survival system. Sorry, guys. So we have 27 counties that have a call. We have 28 calls. And we want to determine how many public AEDs are listed on the National AED Registry, or several AED registries, but we went with the National AED Registry. And our goal is to start listing any unlisted devices. That way that's made available, and then do some promotion on the National AED Registry. But we really want to use that CARES data to determine times and locations of those out-of-hospital cardiac arrest events to see how the system's functioning, how long it takes EMS to respond to those. Did a bystander respond to that? Did they know CPR? Et cetera, et cetera. And then we're going to complete an assessment on bystander readiness within those 27 counties and offer CPR classes where needed. Next slide. And that is it for me. There's our contact information, and I will turn it back over in case there are any questions.
Great. Thank you so much to our panelist speakers. It's always fun to hear the different perspectives. Does anybody have any questions for the panelists? I'm monitoring the chat. I didn't see anything in there, but if you have something, you can unmute right now. We have time, maybe a minute or two for a question.
This is Penny in Wisconsin. I loved all your presentations, and I love the fact that this session touched on all three types of SOARs, because so often I feel like I'm listening to presentations where I'm like, well, that's great, but that works within your structure. So this was really great. Stephanie, you mentioned it was at the end of one of your slides about how you pool the grant funds, and it had something to do with TA. And I was hoping you could explain a little bit more what that looks like and what that means.
Okay, so just to be clear, we with Flex and SHIP, we're pooling them as much as possible. So Flex, the money is supporting all of the critical access hospitals, and with Flex we've got like multiple tiers. So everybody participates in the group work, and then we have regional work, and that might be 5 or 6 cause this month, and then 2 months from now it might be 5 or 6 different cause. Then we have the individual TA work, which only involves 4 to 6 cause where they're working on something specific to them. With SHIP, the way we've done in the past is every call has had its own $10,000, and we've encouraged the SHIPs. We've encouraged the SHIP eligible hospitals to work together as much as possible, but frequently it would be $10,000 to each of the hospitals, unless you were owned by a system that kind of forced you to pull your funds together. The difference we've done with SHIP this year, and I don't know how it's going to go, but we're going to give it a shot, is instead of contracting and having the SHIP eligible hospital pick a project, spend the money, send us a receipt, we have purchased technical assistance, kind of like you do with Flex, so that all that SHIP eligible hospital has to do is look at a menu, and the menu was on the slide of all the different projects they could pick. They can look at a menu and pick one or more. The only thing, the caveat with the or more is you only have so much fund to provide technical assistance. So if they wanted to do something more extensive, they'd have to draw down some of their own money to help pay for that. But basically, all they have to do is raise their hand and say, I want to work on this. They don't have to do invoices. They don't have to do a contract. They don't have to submit a receipt. We've already prepaid for that technical assistance to come to them and do that work. Does that make sense?
Yep. Thank you so much.
Yeah.
Great. Well, thank you so much to the panelists. We really appreciate it. Again, this is recorded. Thank you.